Hello, everyone. My name is Ashkan Lashkari, MOASC president, and today our spotlight on our Researcher of the Month is Dr. Warren Chow, who is clinical professor of the Division of Hematology Oncology at the Chow Family Comprehensive Cancer Center at UC Irvine. He's also associate director for clinical sciences there. He's also an old friend and a mentor of mine when I was a fellow at City of Hope. He's now at UC Irvine. And Dr. Chow, thank you so much for joining us, and congratulations for being our Researcher of the Month.
Thank you, Dr. Lashkari. Appreciate that.
Absolutely. So, Dr. Chow, perhaps you can talk a little bit about your clinical research interests. I know that your area has been focused predominantly in the area of sarcoma and melanoma in your long career. Perhaps you can tell us a little bit more about that.
Yes, I think that I've always focused on sarcomas, more recently a little bit on melanoma. And so I kind of lead the melanoma and sarcoma programs, at least for medical oncology here at UC Irvine. One kind of interest of mine has been immunotherapy for sarcomas, and for a long time really hasn't borne out. And I refer back to one of the trials that we participated in called the Sarcoma Alliance for Research Through Collaboration, SARC 028, which was published back in 2017 in Lancet Oncology. And they used pembrolizumab for soft tissue sarcomas and bone sarcomas. The response rate was, relatively disappointing, 5% for bone sarcomas overall. But for soft tissue sarcomas, there was a hint of maybe some activity, but specifically only in a couple of soft tissue sarcomas, and that was the undifferentiated pleomorphic sarcomas, where 10 patients were treated and they saw 4 responses, objective responses. And the D-diff liposarcomas were 2 responses were noted out of 10 patients. So that's a bit of a hint that perhaps there might be some activity. More recently, the Europeans did a trial called Pembro-Sarc, pembrolizumab and sarcoma. It was published in Nature Medicine in 2022. Their original trial, they looked at pembrolizumab with low-dose cyclophosphamide, and overall, they had only a 5% response rate. But when they looked further on what might be hints of activity, they identified something called a tertiary lymphoid structure, which was like a lymph node within the soft tissue. So when you saw these tertiary lymphoid structures within these soft tissue sarcomas, they looked at that specific subset and they noted a 30% response rate overall, and not just in one particular histology, for soft tissue sarcomas that had this TLS, or tertiary lymphoid structure. So there's a hint of activity that perhaps immunotherapy is effective. And then most recently at the ASCO 2023, the Alliance Cooperative Group reported on their 91902 trial, where cabozantinib and nivolumab were used for angiosarcomas that were previously pretreated with paclitaxel. So you had to be paclitaxel refractory angiosarcoma. And it was remarkable. Cabozantinib 40 milligrams daily and nivolumab monthly at 480 milligrams had an overall response rate in this heavily pretreated group of 59%. So there is a hint of activity that immunotherapy has activity in specific subtypes of soft tissue sarcoma. So we're kind of focusing on that right now.
That's very encouraging. It's always been very challenging that we see immunotherapy so effective across so many different tumor subtypes, and then subsequently see that they're not as effective in other areas. So it's good to see some small pockets where you're seeing some progress. Perhaps you can share some of the clinical trials that you might be leading in the area of immunotherapy or other novel therapeutics in this area.
Yes. Actually, there's one trial, and we haven't given up on chemotherapy. And so I'd like to let you know about one trial. It's run by originated in EORTC, the European group, the European Organization for Research and Treatment of Cancer, and then was imported here to the U.S. to help complete this trial, and is now through the ECOG ACRIN group. It's called EA 7211, and it's known as a Strauss 2 trial. And it's specifically for retroperitoneal sarcomas, particularly leiomyosarcomas and liposarcomas. So in the Strauss 1 trial, the researchers there, led by Sylvie Bonviat, she did a trial of neoadjuvant radiation plus surgery versus surgery alone. And we thought that the clear winner was going to be neoadjuvant radiation with surgery, but disappointingly, there was no difference in outcome between the two groups, and specifically for patients with leiomyosarcoma, unfortunately, they did poor with neoadjuvant radiation. So this is a specific subgroup location with rich peritoneal sarcomas. This led to the Strauss 2 trial. So now the next trial is to use 3 cycles of neoadjuvant chemotherapy with doxorubicin and ifosfamide. So 3 cycles plus surgery versus surgery alone. So surgery alone, again, is the control arm, and now we're trying neoadjuvant chemotherapy. So we haven't given up on chemotherapy. We still think there's a role for that. And we just opened this trial here at UC Irvine. And so we'd be happy to entertain seeing any of your patients that might have retroperitoneal liposarcoma or leiomyosarcoma.
Oh, wonderful. Well, thank you so much. Any final words or thoughts you wanted to share with us? Otherwise,
yeah. One last thing. We've submitted a grant to the NCI looking at a novel doxorubicin. Again, we haven't given up on chemotherapy. So I'm working with scientists at Caltech and who formulated something called SPEEDOX6. And it's a novel doxorubicin that's encapsulated by human albumin. So they can link albumin to up to 9 molecules of doxorubicin. And so you can get a much higher local concentration of doxorubicin at the tumor site. But most importantly, the maximum tolerated dose, you can give grams of doxorubicin without cardiomyopathy and less toxicity. So we hope that with a less toxic doxorubicin and higher local concentration, that this might be more effective for soft tissue sarcoma. So we're concentrating on that. So the grant has been submitted, and we're just waiting for the NCI to evaluate.
well, that's very exciting, and it almost sounds similarly in concept to the antibody drug conjugates, which are essentially using chemotherapy, but with a kind of targeted honing device. Dr. Chow, thank you so much for joining us. We appreciate your time, and we look forward to talking to you again very soon.
Absolutely. Thank you very much, Dr. Lashkari, for having me here in MOASC.
Absolutely. Thank you so much.
Okay, Ashkan.
Bye-bye.